welcoming us back to the multi-system component of our step two, and we'll continue by talking about malaria. So, I know malaria is something we are all very familiar with, and it's basically a protozoal disease that is caused by five species of Plasmodium infection. So, the Plasmodium organism has essentially five species, which include the Plasmodium falciparum, the vivax, the ovale, the malariae, and the nodlesi. So um, most of the time we get to see questions focused on the Plasmodium falciparum because that's the most aggressive form of the Plasmodium. Sometimes we can also get questions testing our understanding of the Plasmodium vivax and the ovale. Yeah, because those ones tends to form a dormant form of this plasmodium, particularly in the liver. So the vivax and the ovale have dormant form in the liver. The falciparum is the most aggressive, that is actually with high mortality and morbidity. The P. malariae is quite indolent. It's not very common, but it's been shown to be highly associated with nephrotic syndrome. So it's good to know that about P. malariae, and all of them they are being transmitted by a particular uh, arthropod, and that is the female Anopheles mosquito. So the bite of the mosquito can help transmit this Plasmodium infection into the blood of humans, and from there it can cause malaria. So just like I've said earlier, the P. falciparum has the highest mortality and morbidity. It's been shown that about 2,000 deaths occurs worldwide every day from malaria. So um, most of the time you have the onset within 24 hours, like the mortality or the mobility can occur sometimes within 24 hours. So it's that bad and virulent. And it's very, very important, very, very important to know that travelers that are going to endemic areas, so travelers going to endemic areas, or um, um, pregnant women that are going to that are traveling should get chemoprophylaxis, because people that are highly susceptible to um, malarial infection include the pregnant women, include people that are traveling to endemic areas. The pregnant women part, you don't even need to be traveling to any endemic area. Once you are pregnant, you are susceptible to developing malaria. So it's good you get um, chemoprophylaxis against malaria. So people traveling to endemic areas, they take it, and to prevent malarial infection, it's very important. You take that chemoprophylaxis, and at the same time, protect yourself. So by using mosquito repellent, using insecticide treated bed nets, covering yourself, wearing clothing, and preventing night outings, because most of those mosquitoes they come out at night. So you want to minimize your exposure um to the mosquitoes. So how's the presentation like? So you are going to get in the question stem that somebody traveled to a malaria endemic area. So like maybe Indian, maybe sub-Saharan Africa, like the tropics of Africa generally. So Nigeria, Ghana, you know, India. So those are malaria infested region, and you are going to notice afterwards that um, the patient present with periodic febrile paroxysm. So the person is having periodic cyclic pattern of fever. So once you see that, you think about malaria. Think about malaria. Periodic febrile episodes is very classic for malaria. And most of the time, the temperature is as high as 41 degrees Celsius. So they can be very, very febrile. And they'll have some other constitutional symptoms like, myalgia, like abdominal pain, like diarrhea. They can have headaches. They contain of tiredness, fatigue, sweating, you know, Just think about any constitutional symptoms you can lay your hands on. Tiredness, malaise, loss of appetite, abdominal pain, diarrhea, headaches, muscle pain. It can last for even as high as 4 to 6 hours. Some can even be more than this. But just think about the periodic cycle of the fever. Think about the constitutional symptoms. Think about the travel history. Those are what you are going to marry together, to establish your diagnosis. And some of them, aside what I have earlier mentioned, they can have splenomegaly, which can occur typically after 4 days of symptoms of onset. And because malaria is associated with intravascular hemolysis, which we are going to talk about by the time we start discussing the complications of malaria, the parasite, after getting entry into the um, bloodstream, they kind of colonize the red blood cell particularly, and because hemolysis, hemolysis. So because hemolysis, hemolysis, and that is why we have some special category of people that are kind of resistant to malaria. It is not mentioned here, but it's important for us to remember that people with the hemoglobinopathies, particularly the AS variant, so the sickle cell trait, people with thalassemia, people with HBC, because these people kind of they have less crisis. Number one, they have less crisis, but at the same time, we have a percentage of our red blood cells being disfigured, being misshapen. So that abnormality or deformation of the shape of the red blood cell doesn't provide adequate space, adequate grounds for the Plasmodium parasite to colonize the red blood cells and proliferate. So that is why they are kind of resistant. So somebody having, it's not only sickle cell traits, like that is AS, even people with HBC, people with thalassemia at the same time are all um, resistant to malarial uh, infection. So that's why people that have the good red blood cell, like people with AA, genotype, they kind of experience more episode of malaria attacks. But the more attack, the more the episode, the higher the passive immunity that the person is going to, you know, I'm sorry, the more the active immunity, because that's going to be active, you're not giving anything to, the more the active immunity the person is going to be developing against the malaria parasite. So it goes both ways, people that get periodic constant infection too with time and they are surviving the episode, with time they will become actively immune to the infection. And people with the hemoglobinopathies like the AS, the thalassemia, the HBC also will become are also naturally resistant because of the reduced surface area of the red blood cell to accommodate the parasite. So we should not forget that. So splenomegaly can occur as a result of the intravascular hemolysis. So when there is intravascular hemolysis, when there is colonization of the parasite into the red blood cell, they are recognized as abnormal by the splenic macrophages. So that is basically the reticuloendothelial cells. And they come out, they kind of chop up these red blood cells, this parasite, and they sequestrate them within the spleen, so causing the splenomegaly. So that's where it will cause. That's where it occurs. And sometimes you can see them, they are asymptomatic between attacks. So that's why we are using the word cyclic fevers. So you notice that they have a fever episode now, later it resolves, later it comes back again because everything parallels with the cyclic destruction of the red blood cell. So when they enter the red blood cell, they lyse the red blood cell, they burst out, the fever episode begins. So by the time they enter new red blood cell and they start their replicative cycle, the fever subsides until they burst out from those red blood cells. That's when the fever, spikes again. So the patient can't have asymptomatic episodes in between attacks for about 2 3 days, depending on the nature of the infection. So 2 days if it's P ovale, P vivax, because those ones exhibit a tertian pattern of attack. So the fever recurs every 2 days, every 48 hours. Why the one that recurs every 3 days or so 72 hours is peculiar to the P. malariae. So that's a Cortian pattern. So it takes about 3 days for the replication to be completed within the red blood cell. Then after 3 days, it ruptures, and that's when the fever spikes. That of P. falciparum might be irregular. Most of the time, it is irregular. Most of the time, it is irregular because it affects different types of red blood cell at different times. So that is P falciparum for us. So sometimes the infection can get so bad, it can cause very severe infection that it can lead to even end organ damage and destruction. So what are the features of severe infection? We are going to notice the hyperpyrexia that is going to be very high as 40 degrees, 41 degrees Celsius. The patient is going to be prostrated. So the way to look at it is just to go from head to toe. So we start from the brain, from the head. So the fever, is going to be very high. The patient will be prostrated. So the patient will complain of fatigue, difficulty standing up. They want to lie down, or they are prostrated. They are severely weak. You know, impaired consciousness. Because of the fact that um, we have the intravascular hemolysis, and you have a lot of um, destruction of red blood cell, minimizing blood flow to the brain. It can lead to impaired consciousness. At the same time, you can have those um, malaria infected red blood cells being sticky. They can adhere to the endothelium of the vessels of the brain, limiting blood flow. So this is the pathophysiology of cerebral malaria. They become prostrated, they become unconscious, they can convulse, they can have neurologic deficit and the like. So it can go to the lungs. We are coming down, goes to the lungs, cause non-cardiogenic pulmonary edema. So basically what we are talking about here is ARDS, ARDS, ARDS. So they elaborate a lot of cytokines, they adhere to the endothelium um of the pulmonary vessels. They destroy those endothelial lining, and you can easily have extravasation of fluid into the lung tissue, causing ARDS. That's that about malaria affecting the lungs, and at the same time, it can affect the liver. Which can present as jaundice. You can have elevated liver markers. It can affect the kidneys because you are having intravascular hemolysis that is limiting blood flow to the kidneys. So this will be manifested as either hemoglobinuria, in which you have a dark colored urine, or elevated um, uh, um, blood urea nitrogen. So elevation of the urea level, elevation of um, the creatinine level, basically talking about AKI generally due to a limited blood flow. So they can also have acidosis, of course, from the intravascular hemolysis. The red blood cells are gone, they are limited. There's limited delivery of oxygen to the tissues. The tissues want to continue their life by following the anaerobic pathway, right? And the product of anaerobic pathway is lactic acidosis. So they have acidosis. And in response to that acidosis, they want to get it out, the respiratory compensation. So they want to hyperventilate to take out the accumulating CO2, leading to hyperventilation. And at the same time, um, malarial parasite can also affect the platelets. Very, very important because the red blood cells that are affected by this parasite kind of express some addition molecules. So those addition molecules are very sticky. They make them very sticky. They can adhere to the endothelium. They can adhere to the platelet. So when they adhere to the platelet, they cause platelet clumping. So leading to consumption of the platelet, bringing about thrombocytopenia, at the same time clot formation. So I can form clot, and when due to aggregation of the platelet, and at the end of the day, when a sufficient amount of the platelet is consumed, there is nothing to help to arrest bleeding again. So they can start bleeding. They can start bleeding. So there are some features that should take our mind off malaria once we see, and that is including rash. You know, Malaria doesn't cause a rash. If we see anything that's looking like malaria, fever, myalgia, headaches, arthralgia, and there's a rash, just think about something else. Maybe dengue, maybe chikungunya. Both of them are also transmitted by the Aedes mosquitoes, not the Anopheles. Rash, think about chikungunya, think about dengue. Skin ulcer, this might be a protozoa, but not malaria. Malaria doesn't cause skin ulcer. Yeah, you can think of maybe leishmaniasis, cutaneous leishmaniasis. Eosinophilia, think about the helminth. Probably this person has strongyloides saccharides or ascaris lubricoides infection with fever. Lymphadenopathy, it doesn't cause lymphadenopathy. Other infections can cause lymphadenopathy, but this is not peculiar to malaria. Neck stiffness, think about those cause of meningitis and photophobia. Think about the cause of meningitis, Neisseria, meningitis, think about strep pneumo, hemophilus, but not malaria. So these features, are suggestive of an alternative diagnosis. Very important stuff. So how do we make um, diagnosis of malaria? So timely diagnosis is actually very important because we have said it, particularly with respect to the pill falciparum, which is very, very fatal. So it can cause death as quick as possible within 24 hours in some situations. And it has been discovered that majority of the colonies where malaria attacks is prone, they are kind of resistant to chloroquine treatment now. Chloroquine used to be the drug of choice in the earlier years, but right now, because of incidents of resistance, we no longer use chloroquine. So you must not pick chloroquine in the answer. Don't ever fall victim for that. So because there is often resistance to standard chloroquine treatment. So you want to look somewhere else. So yeah, we are still talking about the diagnosis. How do you want to make diagnosis? So most of the time we just make diagnosis by doing microscopy. Yeah. So you just make your blood smear, you stain it with the Gimstar or the white stain. So you use your Gimstar stain or your right stain, and you make your smear, you look at it under the microscope. So most of the time the laboratories prepare two films. So they make the thick film and the thin film. So the thick film will help you identify the organism that this is Plasmodium. It might not tell you the type. Is it Falciparum? Is it Vivax? Is it Ovale? Because to do that, you have to look very, very thinly, very closely to be able to separate them. But your thick film will help you to quantify the parasitemia that, okay, this is actually Plasmodium. I can see the trophozoite ring, but I don't know the type because I have to look closely. But I know that this is the trophozoite ring here, and I can quantify the number of parasitemia that I'm seeing. With your thin film, you will be able to tell the specific species that you are looking at. So they both have the role that they play. So so that is that. So your thick film will help you to identify that this is Plasmodium, this is Plasmodium you are looking at. Your thin film will help you to identify this particular species, the particular species, and you can also use to quantify the amount of organisms that is there. Either 1,000, 5,000 per microliter of blood or 2,000. So don't forget, your thick one will help you to identify that, okay, this is plasmodium. Your thin one will help you to look at the species, and also both of them, they can help uh, um, identify the degree of parasitemia. So that is very important. Um, yeah. So what are the laboratory features? So you want to do your blood smear. You want to do your blood count, rather complete blood count. And what do you expect? Because your complete blood count, you are looking at your white blood cell count, you are looking at your platelet, you are looking at your red blood cells. So for the red blood cells, because of the intravascular hemolysis, you are going to see pneumocytic, pneumochronic. So the same size, normal size, normal pigmentation of the hemoglobin. So pneumochromic, pneumocytic anemia with reticulocytosis. We already know that reticulocytosis is a sign of hemolysis. It is a bone marrow response to hemolysis. So you are going to see pneumochromic pneumocytic anemia with reticulocytosis and thrombocytopenia. Thrombocytopenia because we have said it that the red blood cells become sticky, they adhere to the platelet, they consume the platelets, leading to bleeding. So they can cause thrombocytopenia, and this is very, very early in the infection. So most of the time, you don't have disturbance of white blood cells. in malaria. It's not very, very common. So that's why lymphadenopathy is not a common stuff that you kind of experience in malaria. So, if resources allow and you want a very quick one, you can do your PCR analysis looking for the gene sequence. You can do your rapid antigen test. We kind of use this rapid antigen detecting some particular enzyme component of the infection, like aldolase and the likes. We can do fluorescent antibody method, but the most important stuff to remember is just the blood picture. What do you see? So, um, you are going to see the by the time you do your smear, you see your trophozoite. If it before I miss it out, if it the P falciparum, you are going to see the trophozoite ring having the headphone um pattern, like something like what we have here, this double headphone stuff. And we are going to see the crescent shape dermatocytes. So the male or female dermatocytes, they are going to appear like subdural hematoma, crescent shape, moon shape. And um, the Vivax, we are going to see the trophocyte ring. They are not going to have the headphone pattern, but you are going to see an additional structure that I call the Schaffner stripping. So that's just like small red granules within the cytoplasm of red blood cells, peculiar to the Vivax and the Valley. And the P. malariae just have normal trophocytes, in them. And yeah, so that is that about, how to identify on the blood smear, what you see. We have talked about what is going to happen to the blood level. There's going to be pneumocytic, pneumochromic anemia, reticulocytosis, and thrombocytopenia in low resource setting. In sorry, in when resources are available, you can do your PCR, you can do your fluorescent antibody methods. Rapid antigen test kits are actually readily available in most centers, so you can do that quick to make your diagnosis. And in patients with altered mental status, particularly in children, you must do a finger stick glucose through loss hypoglycemia. Though hypoglycemia can also be a complication of malaria because the parasite is actively replicating. They need a lot of glucose to facilitate their replication. So that might be a cause of hypoglycemia. Cerebral malaria is one of those severe complications, just like we have said. The malaria parasite can easily adhere to the endothelial lining of the blood vessels in the brain, and they can occlude those vessels, reducing blood flow to the brain. So they can present with headaches, altered sensorium, confusion, neurologic signs. So they can have weakness in a particular part of their body. They can have seizures. Most of the time, what brings them to the hospital is a seizure. Most of the time, they have severe convulsions. And then because of the thrombocytopenia, they can have bleeding into their retina. So retinal hemorrhage. And of course, delirium, because they'll be confused. So if you don't act quickly, it can progress to coma and eventual death. So very, very important. Cerebral malaria is very important to keep our heads. Very common in children. High fevers, headache, neurologic deficit, seizures, confusion, and coma if not acted promptly. Um, treatment. Treatment. So how do you treat malaria? Most of the time, you can have uncomplicated malaria. Most of the malaria that most of us have is uncomplicated. So you can just treat with oral agents. But we have said it that chloroquine is kind of outdated now. Nobody talks about chloroquine because of the high rate of resistance. So you want to use other oral agents. So don't forget, look at the roots. We are talking about oral for uncomplicated. So you are seeing someone that are having high fever, malaria, weakness, nausea, vomiting, anorexia. No problem with the liver, no problem with the brain, no problem with the kidneys, uncomplicated. So you just give oral medication. So you can use mefloquine, you can use atovaquone, proguanil. So atovaquone, proguanil, pregnant. So that's very important. Pregnant, very toxic in pregnant people. People that are pregnant or breastfeeding. Pregnant people. Um, Then artemisinin. So for severe case, so most of the time we reserve the artemisins for people that have complicated malaria. So that's the way it works. We can use oral mefloquine, oral atovaquone, um, proguanil for people that have the uncomplicated form, and people that have developed the severe form. You can give artemisinin-based combination therapy, right? ACTs. Um, In the cases of the Vivax and the Ovale, you must add primaquine to take care of the liver hypnozoids. Yeah, to eradicate the hypnozoids of the liver, because those are the dormant form and they can be released into the blood intermittently to cause red blood cell destruction. So you don't want that to happen. So in addition to our standard treatment, you want to give primaquine. So once you cannot identify the species, or you identify the species, it is Vivax, it is Ovale, any one of those two, you must add primaquine to treat the hypnozoids. Very important to remember that people traveling to endemic regions, you must give them prophylaxis. Very, very important. You must give them prophylaxis, and the prophylaxis is used 3 times. You give them 2 weeks before they travel, so that you can start building up the level of the drug before they travel. Then, while they are traveling, they also need to use it so that you can maintain a constant amount of the drug. And 2 weeks after they come back, 4 weeks after they return. So they must use it 4 weeks after they return to eradicate any form of parasite that they might have gotten. So very important. You use it 2 weeks before, while they are going, 4 weeks after returning. Very, very important, particularly when there's history of traveling to the endemic parts of the world where malaria is, like Asian parts, like in India, like Africa, Sub-Saharan Africa, and the likes. So there are some situations where we have contraindications to use of some certain anti-malarials like primaquine. You don't want to use primaquine in anybody that has tested positive for GCSPD deficiency. So once there's deficiency of GCSPD, you don't want to use primaquine because the person is playing with hemolytic anemia. Mefloquine, so Meflo kind of irritates. I see mefloquine as an irritant. It is a drug that you use weekly, and just see it as an irritant that can irritate the brain, causing psychiatric problems. So they just become anxious, they become depressed. It can irritate the brain, leading to seizures. It can irritate the heart, leading to arrhythmias and conduction problems. So you discontinue mefloquine immediately. Once any of these happens, you don't continue it again. So irritant, mefloquine. Atovaquone, proguanil, we have said it, that pregnancy. So you don't use it in people that are pregnant, that are breastfeeding, and as well people with renal disease. Chloroquine, is a very common trigger that can provoke, psoriasis. So it can lead to development of psoriasis, and most commonly, particularly in Africa, people tend to have this itchy experience with the use of chloroquine. So people have pruritic episodes. They can have psoriasis, then commonly to blindness. They can have deposition of this pigments of this chloroquine within the retina, leading to blindness. So they can have eye vision issues. They can have skin issues like pruritus, hypopigmentation. They can have psoriasis as well. So very important to remember. Don't forget primaquine, GCSPD, mefloquine irritant, the brain, seizures, psychiatric episodes, and the heart conduction defect. Atovaquone, proguanil, you don't want to use it in people that are pregnant, in people that have renal problems. Chloroquine, psoriasis, vision, skin issues. We have talked about the complications. We know the pathophysiology of cerebral malaria, how it occurs. We know the presentation. It can cause severe hemolytic anemia, dropping the hemoglobin level to as low as 7 below. It can cause renal impairment. Renal impairment, we know AKI, right? The AKI can be pre-renal, it can be intrinsic. Intrinsic in people with hemoglobinuria, forming um, um, nephrotoxic insult to the renal tubule. So that will be intrinsic. It can be pre-renal because of the intravascular hemolysis reducing blood flow to the kidneys. So anyone, depending on what our lab is telling us. So we are looking at the blood urea creatinine, we are looking at the fractional sodium excretion to be able to ascertain which is which, but we don't really need to go to that level because once you treat your malaria, you are okay. So, you know, everything still follows same treatment of malaria. So we don't really need to be going to be finding out what type of renal impairment the person is having. But it doesn't make any difference. The non-cardiogenic pulmonary edema, we have said this, that is ARDS that results from damage to the endothelial lining of the pulmonary vasculature, causing extravasation of fluid into the pulmonary tissue, leading to the cardiogenic edema because there's no problem with the heart. Hypoglycemia from increased metabolic consumption by the parasites and at the same time liver problems. So if they have problem with the liver, glucose is produced from the liver. So gluconeogenesis occurs there. So when the liver is decompensated in a way, they cannot adequately produce enough glucose and there's hypoglycemia. Even most of them are not even eating very well. So can have hypoglycemia from that. The severe hemolytic anemia can lead to reduction in the level of oxygen, anaerobic pathway is activated, lactic acidosis is a product. Acute hepatopathy is what we have talked about. Reduction in the blood flow to the liver, disrupt liver activity, elevated liver enzymes, bilirubin, you know, causing hepatic manifestation. And because of the fact that the inflammatory process, the weakened uh, immunity in a way can predispose them to developing gram-negative bacteremia. So this is very common. We should not forget this. We should not forget this. They can also have gram-negative bacteremia episode, but it's not something they regularly test most of the time. So either they give us problem with the lungs or they give us problem with the brain in cerebral malaria, particularly in children, or hypoglycemia or problems with the kidneys. So we have other mosquito-borne viruses. So there are other viruses that are transmitted by other species of mosquito, particularly the Aedes mosquito. And what is common to them is the fever, the rash, and the myalgia. So they have fever, rash, and myalgia. So three of them we are looking at: the chikungunya, the dengue, the Zika. So we know all about chikungunya in our step one. Chikungunya is the virus that belongs to the toga or the Flavividae family, right? The toga or the alpha. Sorry, not Flavi. I'm sorry. So sorry about that. Chikungunya, toga, alpha. Viridae, right? And one thing that is peculiar to chikungunya is the fever, the the rash, the maculopapular rash that they have. So they have fever, they have a maculopapular rash, they have headache, and they have inflammatory arthritis. But what separates the arthritis of chikungunya from dengue is that most of the episode of chikungunya will have a joint swelling. So dengue can have joint pain, but you don't typically have a joint swelling. But in chikungunya, you see the joint pain, you see the joint swelling, you see the fever, the rash, and the headaches. Leukocytopenia, thrombocytopenia is not very common in chikungunya. It can occur, but it's not very common. It is not very common. Uh, and how do you make diagnosis of chikungunya? Because this RNA virus, so you must do a reversed PCR. So you have to change it back to DNA. Then you do your PCR analysis. So that's why I call it reverse PCR. So most of the RNA viruses, you have to do reverse PCR. But for DNA virus, you can just do a straightforward PCR. Then chikungunya diagnosis is reverse transcription PCR. You can do serology, right? Then how do you treat? You just basically do supportive treatment, supportive treatment. You can give steroids. You can give DMAT. Drugs that modify the, the process of rheumatoid arthritis. Um, like hydroxychloroquine, sulfalaxine, methotrexate to treat the joint problem because chikungunya is actually with arthritis, with joint swelling, so which mimics that of rheumatoid arthritis. So the steroids and the DMAT can help with that. So you don't have any preventive methods. You cannot prevent it with the use of vaccine. What you can do is to avoid the mosquito bite. That's all about chikungunya. Dengue is the brother of chikungunya. You call that the breakbone fever. So they have very close differential for malaria. And just like chikungunya, dengue is associated with the fever, they have the headache, they have the inflammatory rash, which is the maculopapular rash. They can have the arthralgia, they have myalgia, and they have neutropenia. Very important, very, very important. You see the leukopenia, specifically neutropenia. You see the headache, you see the fever, you see the maculopapular rash, you see the arthralgia, but you can see the joint pain, no joint swelling, and you have this characteristic retroorbital pain. So once you are seeing that, you are thinking of dengue fever, but you remember that dengue occurs in the spectrum. So we have dengue fever, we have dengue hemorrhagic fever, and we have the dengue shock syndrome, right? So the dengue fever is just fever, the retroorbital pain, which is manifesting like the headache, the arthralgia, right? The maculopapular rash, and the neutropenia or the leukopenia. Very important. Then they can now progress, you know, and lead to the dengue hemorrhagic fever. And here, what is happening is that the dengue virus is now getting very virulent, particularly when somebody gets infected by another serotype of dengue. So the person gets infected by serotype A, then later the person gets infected with serotype B. By the time that serotype B is entering, it's not going to cause dengue fever, but it's going to cause dengue hemorrhagic fever. So that is due to antibody dependent entry. So it's using the antibody from the previous infection to gain entry into that person's blood and tissue. So that response is going to be much more virulent than the previous one. And what is going to happen here? The virus is now going to cause a severe damage to the endothelium. So when there is a damage to the endothelium, there is kind of a gateway that is opened for red blood cells, for platelets, for plasma generally to escape into the tissue space. So when there is loss of fluid, loss of platelets, there's going to be thrombocytopenia. There's going to be thrombocytopenia, right? Because of the loss of platelets into the tissue space. When there's no platelet, what happens? The person starts bleeding, right? So there's dengue, hemorrhage. The thrombocytopenia characterized by bleeding. And due to the fluid loss, there's going to be hemoconcentration. So you notice that the red blood cell count is going to be high. So that's another thing that will help you separate it from malaria. Malaria can have bleeding, can have thrombocytopenia, but they will not have high red blood cell. There's not going to be hemoconcentration. So most of the time, you are going to see pneumocytic, pneumochromic anemia in malaria because they are actively destroying those red blood cells. No time for hemoconcentration. But in dengue, you are going to see hemoconcentration. So pay attention to that. The thrombocytopenia is going to be there. The bleeding is going to be there. And when there's severe bleeding, what happens? The person will go into shock. And what are you looking at in shock? You are looking for the hypotension. You are looking for the tachycardia. So don't forget hypotension, tachycardia, hypotension, tachycardia, hypotension, tachycardia. Think about shock. Think about shock. So from the bleeding, there's reduced perfusion to the liver. There is elevation of the liver marker. So don't get distracted and start thinking about the hepatitis. Marry all these symptoms together. History of travel to maybe Southeast Asia, mosquito bites. You are seeing fever, headache, retroviral pain, maculopapular rash. That is not going to be explained by hepatitis. That is not going to be explained by malaria. That is dengue we are looking at. So how do you treat? Because of the bleeding, because of the shock, you must give fluids. Initial stabilization with your isotonic fluid, ringers or normal saline. Then later, when blood is available, you transfuse blood. And this one has a vaccine. There's a dengue vaccine that uses the yellow fever backbone. You can also make diagnosis by doing your reverse transcription PCR as well as your serology. Very important. Then the last here is Zika virus, Zika virus, Zika virus. Zika virus is also transmitted by the Aedes mosquito bite. Yeah, very common in Africa, all the areas where you have the Aedes mosquito. And the presentation is essentially CPR, just like we have in our step one, CPR. So the C for the conjunctivitis, the P for the pyrexia, and the R for the rash, the itchy rash, the itchy rash. So the CPR, don't forget, we talked about the non-itchy rash of Still's disease yesterday when I was talking about the the causes of fever of unknown origin. I was talking about the autoimmune component, and I mentioned um, still disease. So that's the way to learn. You keep saying all these things to yourself. You keep looking for distinguishing feature between one condition and another condition. That's how you can cement all those things to memory. So still disease, we talked about the fevers will be there too, but they will have a bumpy salmon colored maculopapular rash that is non-itchy, right? We talked about the leukocytosis, you know, and we talked about the arthritis, right? Which lasts for more than 2 weeks. Then we can have some systemic manifestation like lymphadenopathy, like hepatosplenomegaly, and high ferritin, but negative rheumatoid factor, negative ANA antibody. Very important. Uh, so Zika, not to digress too much, CPR, conjunctivitis, the itchy rash, and the what? The pyrexia, which is a fever. You can have headache, is the constitutional symptoms. Zika, just like Campylobacter jejuni, is associated with Guillain-Barré. So maybe 1 or 2 weeks after the Zika infection, the person started developing ascending, paralysis and weakness, loss of deep tendon reflex. What is going on here? This is likely to be Guillain-Barré. And you quickly want to assess, the respiratory function. You want to do your maximal inspiratory pressure measurement. You want to check for your vital capacity to ensure that the person is not going into respiratory compromise so that you can quickly act by intubating. Basically what you need, Guillain-Barré. Um, so how is Zika transmitted? So Zika can get in through the headaches, but at the same time, particularly in pregnant mother, they can move it to their fetus vertically, transplant center. And Zika can also be moved from one person to another through sexual contact. So a person can get it through the Aedes mosquito bite, but they can also share it vertically through birth during pregnancy period and sexually. Very, very important. So it is a very serious problem for the baby during pregnancy because it can lead to miscarriage, number one, and secondly it can lead to congenital Zika syndrome. So congenital Zika syndrome. And what we are just going to look for, on imaging is what? Subcortical calcification. We know that almost all these stuff have calcification, like the periventricular calcification in TMV, the intracranial calcification in TOXO, but here we're having a subcortical calcification. So calcification affecting the basal ganglia. Sometimes you can see it in the cerebral cortex, but most commonly it's very common in the basal ganglia, the subcortical structures, right? And we are going to see evidence of ventriculomegaly, but don't be deceived. It is only the ventricles that are enlarged. The brain matter itself, the parenchyma of the brain is not well developed. It is small. And that is what is going to determine the size of the brain, the size of the head. So because the brain volume is very small, even though the ventricles are enlarged, it's going to lead to microencephaly. So that's when you're now going to see hemohem. By the time you deliver the baby, what you are going to see is hemohem. By the time you do your imaging, what you are going to see is subcortical calcification and what? Ventriculomegaly. But when you deliver, you see hemohem. You remember hemohem. So hem standing for the motor complaint, spasticity and the likes, the O ocular, and the last M, the microencephaly. So we see the baby is having small head, tiny little head, microencephaly. The O, talking about the ocular manifestation, so we can have blindness because the same, you have some pigmentations in the eyes, some deposits there. Then the last M is the motor symptoms, talking about spasticity, seizures, and the like. So the treatment is essentially supportive, just give supportive management for Zika syndrome. So, so we continue our discussion by moving on to Lyme disease. So we are now talking about the tick-borne infections. Um, so Lyme disease is the first, and Lyme disease is one of those tick-borne disease, which is caused by a particular spirochete. So the bacteria that cause Lyme disease is spirochete known as Borrelia burgdorferi. So this is the organism that is involved. And the vector for this organism is the Ixodes tick. The Ixodes tick. and you typically find these ticks feeding on the white tail there or the white foot mouth. So that is not very important. What we need to know is the implicating organism, and that's the Borrelia. The vector for this organism, the axodistic. So when the axodistic feeds on an individual, it can easily release this Borrelia burgdorferi parochete organism into the blood, and from there, Lyme disease can develop. You typically find these ticks within some part of the US, which includes the northeastern state and the northern Midwest states. So the northern west, the northeast, and the Pacific coast. So that's where you see um, the exotic. So I don't really, it's good to know it, but there are so many states here, so we can start memorizing everything. So the most important thing is just to pay attention to the clinical picture, which will um, go a long way in helping us rather than just channeling our energy, learning all those states of the US. But before I move further, let's just chip in the ehrlichiosis as a key fact. So ehrlichiosis, just like Lyme disease, is also transmitted by a lone star tick. So not Ixodes tick now. This is a lone star tick. Is also known as the amblyoma tick, but this one is endemic to the south central, the south eastern US, or like the Lyme, which is northeast, northwest. This one is south central, southeast. So um so definitely I'm going to go over the Lyme disease again so that we don't get confused. So let's focus on the ehrlichiosis for now. So ehrlichiosis transmitted by the long star tick, which is endemic to the the south central and the southeastern part of the US. The patient after the tick bite typically starts presenting within 1 or 2 weeks with the constitutional symptoms of fever, headache, malaise, arthralgia, tiredness. you know, and they sometimes have GI symptoms. They have GI symptoms. They can present with abdominal pain, diarrhea, vomiting. They can have problems with the liver, hepatosplenomegaly, and the spleen too. So hepatosplenomegaly, they can have um, um, hepatomegaly. Sorry, please. I'm sorry for that. If they usually have hepatomegaly, doesn't typically affect the spleen. It can, but most of the time, just hepatomegaly, problem with the GI, which is abdominal pain, nausea, vomiting, diarrhea, the constitutional symptoms, and in some situation, particularly in children, you see a pinpoint rash, which could be petechiae. Most of the time, it is petechiae. So you see this pinpoint petechiae rash. In about 30% of adults, you see the rash. In about 60% of children, you see the rash. So, because it affects the liver, definitely you are going to see elevation of the liver markers. So there's elevation of ALT, elevation of AST. It kind of affects the bone marrow. So there's suppression of the bone marrow. So there's leukopenia, there's thrombocytopenia. There can be anemia too. So leukopenia, thrombocytopenia, elevation of liver markers, those are the laboratory findings you expect in an individual with ehrlichiosis. And doxycycline, of course, is a drug of choice. Further blood investigation, for example, when you do the smear, you can see um, the monocyte, impregnated with the morule. So morule is just more like part of the germinative form of the Ehrlichia infection. So the morule, you see them inside, engulfed within the monocyte. So it's not the confirmatory test. Yeah, it might be there, it might not be there. It may be there and the person still doesn't have ehrlichiosis. It might not be there and the person might have ehrlichiosis. So it's not confirmatory. So what you do typically to confirm it is to do your indirect immunofluorescence test. So assaying for the antibody titer against the Ehrlichia organism. So Ehrlichia chafensis, that's the most common organism. that is being translated by the lung static that cause this ehrlichiosis. So you try to do your immunofluorescence, there's the indirect form. So checking for that antibody, and you notice that it rises more than fourfold. So once you see an elevation of the antibody more than fourfold, on your indirect immunofluorescence testing, then you can say an individual confirmatorily has ehrlichiosis. So I have to tell us that ehrlichiosis is a clinical diagnosis. So, you know, once you know that the individual is exposed to the tick bite, the person lives in an area endemic to the Ehrlichia organism, which is south central southeast eastern part of the US, and you can see the presentation, the constitutional symptoms, the hepatomegaly, the diarrhea, the nausea, vomiting, and the block work, you can make your diagnosis. Typically, it's just clinical. You see the rash, which is not very common, but you can see the particular pinpoint particular rash, the abdominal findings, the constitutional symptoms, the tick bite, then the locality. You can marry all those things together to make your diagnosis, but they try to make our life easier by giving us part of the blood work. They can give us the smear findings showing the morule in the monocyte to facilitate our diagnosis. Sometimes you can see the blood work, you can see the white blood cell count is low, but you see that the fraction of the monocytes might be elevated. So that can also give us heads up to the fact that these guys are actually thriving within the monocytes, making the monocytes, to be abundant in its production. So Doxy, don't forget Doxy is a drug of choice. So back to Lyme disease. Lyme disease caused by the Borrelia burgdorferi, just like ehrlichiosis caused by Ehrlichia jaffensis. So here is Borrelia burgdorferi transmitted by the Ixodes tick, which is confined or localized to some part of the US, the northeastern, the northwestern and Pacific coast, right? And just like ehrlichiosis, people with Lyme disease can have some constitutional symptoms like the fever, the malaria, the fatigue, the headache, myalgia, arthralgia. This can happen in so many infections, so it's not very specific. But what are those things we are looking at for? Because we remember that the infection occurs in stages. The primary stage, which is the early localized, the secondary, which is the early disseminated, and the tertiary, which is late disseminated. And it's important for us to know that the Lyme disease typically develops when the tick feeds for 36 hours. So if the tick has not fed for more than 36 hours, forget it. The person cannot develop Lyme disease. So the tick must have sucked blood for more than 36 hours for you, to make to be sure that okay, there's a tendency for an infection to happen. So that's even part of those criteria we have to consider before we give an individual prophylaxis against this infection. You must be able to ascertain that these individuals have had a tick bite or tick feed for over more than 36 hours. You can assess this by looking at the size of the tick. How big is it? Is it enlarged from sucking blood, or has the person stayed in that area for more than 3 days or more than 36 hours? 36 hours is not even 3 days. 36 hours should be like a day and a half or so. So if the person has stayed for like 2 days onward, you can be rest assured that okay, this person must have had a tick bite and the tick must have fed for more than 36 hours. Um, so for the primary early localized disease, what we just noticed that we noticed that after the feeding, about a week afterwards, you notice the um uh so like few days to a week, you notice appearance of the erythema migrans, so which has a bull high appearance. We know how this looks like, so it is not strange to us. This is how it looks like. So we can see the target sign here. So yeah, so the zone of clearance, the outer erythematous area, the innermost layer. So that is talking about the distribution of the rash, how it happens. And once you see this, you raise our suspicion for erythema migrans from Lyme disease. So we notice that this rash will expand, over some days, and it start appearing in multiple areas of the body. So don't forget, this macular raised rash with a central clearing and a innermost target sign. That is the bull-eye appearance for erythema migrans. Um, so that is that. So it usually contains this outer ring where you find the spirochete. So here is where we find the Borrelia organism. That's where they are. You see an inner ring of central clearance and the central erythematous area, which is the innermost. So that is just an allergic response to the tick bite. So here is the allergic response. This erythematous area is due to allergic response to the tick bite. Here is just the area of um, central clearance and innermost area. This is where you find your spirochete being deposited. So, so the secondary phase or the early disseminated phase, um, you just have to remember phase. So that's the acronym we need to remember. Phase. So phase is just standing for F for the facial nerve palsy. Bilateral. It's important to emphasize that bilateral facial nerve palsy. Bilateral facial nerve palsy. A, talking about the arthralgia. So they have this transient arthralgia, transient myalgia, transient arthralgia, transient myalgia. The C for the carditis. So the carditis can span over so many problems. It can be myocarditis, can be pericarditis. They can have conduction abnormalities, particularly third degree heart block. So that's what most of us typically remember, which is good. But it's not only conduction abnormality that they can have. They can have myocarditis, they can have pericarditis, from from the infection at the second stage. Then the E is talking about the multiple erythematous, multiple erythema migrant rash. So you start noticing spread of that rash beyond area where the tick did not even bite. So it starts spreading outwards, the facial nerve palsy, which is bilateral, and they can also have lymphocytic meningitis. So that's more like the cranial manifestation, the CNS manifestation. So remember the facial nerve palsy, the meningitis, the A is standing for the arthritis, the myalgia. So they have this transient arthritis, transient myalgia. They have carditis, third degree heart block, myocarditis, pericarditis, the yeast, multiple erythematous rash. Then the tertiary stage, you just have to remember two things, arthritis and encephalitis, that is all. So here, the transient arthritis that they are having at the secondary stage is now becoming prolonged, right? So it's occurring for more than 6 months and typically affect the large joints, see it, the knee, you know, you can see it in the knee, affecting the ankles, the knee, for for a long time. So it's now chronic arthritis and the subarachnoid encephalitis, which is called the late neuroborreliosis. So they can start having memory loss, they have mood changes, they have personality changes. Here too, they can have polyneuropathy, sensory changes and the likes, feeling tingling sensation in their body parts, you know, that is characteristic of the tertiary stage. So we should not forget the early stage. We just see the erythema migrans, that typical rash with an outer erythematous area that contains the spirochetes, the middle central clearance, and the innermost area where you have the allergic response to the tick bite. You have the secondary stage where you have the face acronym. So you want to remember the F, the facial nerve palsy. You want to remember the lymphocytic meningitis. Then you want to remember the A for the arthralgia, myalgia that is transient. The C for the carditis, which can be myocarditis, pericarditis, that conduction problems, third degree heart block. Then the multiple erythema migrans, the transient, the chronic arthritis, the encephalopathy or the encephalitis, which is characterized by mood swings, memory problems, personality changes. So, how do you make diagnosis? So, the early stage, you can make your diagnosis by just your clinical presentation alone. So, we are just looking at what we have. So, we can see the typical erythema migrants, and the person is living in the endemic area. So, where is the endemic area? The north, where? The northeast, the north west, as well as the Pacific coast. So anywhere will in the state within this region with the erythema migrants, you can think of early Lyme disease. And one thing I know for sure is that they won't really give us most of the time. If you see erythema migrans being described in the question, trust me, that location is going to be within an endemic area. They are not that wicked, and I'm sure they know many people are taking these exams from different part of the world. So we can't all be learning all the states within these areas and the like. So most of the time, once you describe that lesion, it's going to be within an endemic area. So we rest assured, and that is going to be the early Lyme disease. If those are the only things you are seeing, your erythema migrans only, just a single lesion. So at this point, you don't need to do any serology to make your diagnosis. You don't need it. You don't need it. So you can commence your treatment immediately at that point. And because if you try to do serology, your IgM might not be positive until a week or 2 weeks after, and the IgG takes a longer time, which is about 2 to 6 weeks. So after the onset of the erythema migrans. So why should you be waiting for serology when you have seen your erythema migrans? So give the person the appropriate antibiotics, which is typically doxycycline. Just like in ehrlichiosis, you still prefer to use your doxycycline, but if this individual is pregnant, you want to consider amoxicillin. So you don't give doxy. If the patient is pregnant, you can give amoxicillin. Okay, then for the early disseminated or the late Lyme disease, so you are seeing somebody presenting with features of the face, and then for the late, you are seeing the neuroborreliosis, which is encephalitis, the chronic arthritis. Then okay, this is likely to be late. So the person living in areas where Lyme disease is endemic and the like. So you need to confirm. So that's where you now do your serology. So what test of serology do you do? What serological test are we talking about? ELISA. So do your ELISA to assay for the IgM and the IgG. So if they are positive, good for us, but we don't stop there. We still need to continue. If it's negative, we stop. But if it's positive, we move on. you know, we move on. But if we can't really say what the test is saying, is it positive, is it negative, that is equivocal. We don't know if it's positive or negative. We have to go forward by doing our Western blot. So the reason why we don't go to Western blot directly is that Western blot has a lot of false positive results. So we need to get something that is positive first, so that we know that, okay, the positive we are getting in Western blot actually confirms the diagnosis. So you don't just jump to Western blot. So you do your ELISA first, if it's equivocal or it's positive, then you now go ahead to confirm definitely with your Western blot. And Western blot, if it's positive, then you can be rest assured that what we are dealing with is early disseminated or the late disseminated form of Lyme disease. And what do? We give the appropriate antibiotics, which is what not doxycycline, because this is early disseminated now or late disseminated. Once it's disseminated, you don't use doxycycline. You give ceftriaxone. Ceftriaxone is what we are going to give. IV ceftriaxone, IV ceftriaxone, IV ceftriaxone, IV ceftriaxone, IV ceftriaxone. Very important. Okay. So I've already talked about the treatment already. If the tick is still attached by the time we are seeing the patient, remove it clean with a faucet gently, and you disinfect and clean that area. Very easy. That's what we do. For the early treatment, early stage, that is the primary stage, which is the erythema migrans alone. You just give your doxy. If the patient is pregnant, you give amoxicillin. You want to make sure you are using a short course, less than 21 days in young patients. Yeah, because we know doxycycline can cause a lot of problems, like it's like tetracycline, problem with the bone, problem with the dental area, causing staining of teeth and the like. So you don't want an adult that's going to be having brown teeth. So for the ladies, so we have to look sharp. So for more advanced disease like a problem with the heart, the CNS, the joint, that is the secondary disseminated, the tertiary disseminated, you have to give IV ceftriaxone for that individual. Yeah. So um so that's just basically what the treatment is all about. So consider empiric treatment, people with characteristic rash, arthralgia or a tick bite if acquired in the endemic area. So once you see that, you know, individual with the rash, erythema migrans with arthralgia, tick bite, you start your treatment while you confirm. So very, very important, very, very important because you don't want the stuff to progress quickly into a more advanced stage that can um, affect the patient. So the way you can prevent it is just to avoid tick bite. So don't go inside a bush where you can get exposed to the tick. So in some situation, you might need to give prophylaxis. So and the prophylaxis just involve one dose of doxy. Please don't forget this statement. One single dose. Just like we are treating um gonorrhea. Single dose IM ceftriaxone. So here, single dose doxy. Single dose doxy is what we give for the prophylaxis. So there are some certain conditions or criteria that must be met before you can consider an individual for the prophylaxis. So you have to see the tick. You see the tick that okay, this tick that is attached to this person is the Ixodes scapularis, not amblyoma or lone static, but Ixodes scapularis. So once you see that, and you can be rest assured that that tick has attached for more than 36 hours. Okay, because we have said it that it takes 36 hours or more for the tick to cause infection, right? So the way you can estimate that is to ask the patient how long has the person been in the bush or in the neighborhood where the tick, got into the person. Is it more than 2 days? Okay. Or you look at the tick, how big is it? Because the feed, they get engorged with blood and they get swollen. So you can use that to just clinical judgment to estimate that okay, it has a very high tendency that the tick has been attached for more than 36 hours. Then you must ascertain that you can begin prophylaxis within 76 hours, 72 hours. That you can begin the prophylaxis treatment within 72 hours. So if the prophylaxis is not available within 72 hours, don't bother, doing anything. So that you must be sure that you can start the prophylaxis within 72 hours or less. So you must also ascertain that that individual has no contraindication to doxy. The person is not pregnant, the person doesn't have any history of allergy to doxy, you know, no contraindications to doxy, and the person is living in an environment where the Borrelia organism is endemic. So that one kind of overrules this 20% rule. So they say the local rate of infection is 20% or more. So where the local rate of infection with the ticks carrying the Bacterophora borrelia is more than 20%. So most of the time when an individual is living in an area endemic with these ticks, most of them, the infection rate is more than 20%. So because that's just a quick way to figure it out. So don't forget, you must identify that tick. See that okay, this tick and this tick has been feeding for more than 32 hours. You can provide the prophylaxis within 72 hours or less. The person doesn't have any contraindications to doxy, and the local infection rate with the Borrelia organism is more than 20%. So when all these criteria is met, you can also give one dose of doxy, right? Prophylaxis. Mind you, you are not seeing any rash yet. You are not seeing anything. So that's why you are giving proxy. The I said proxy, the prophylaxis. So because you are having a very high suspicion that okay, this individual um has a very high tendency of developing this Borrelia burgdorferi infection, the Lyme disease. So you can quickly respond by giving your prophylaxis. So tick testing is usually the most current answer choice. So don't pick tick testing. Don't pick it. So just pick the one that talks about the treatment most of the time. You see the rash, start your treatment. You don't need to be waiting for any investigation. Most of the time, they will give you the erythema migrans, as a major presentation, majorly in the primary stage, and you give your your dogsy. Don't fall trap and be saying you want to be testing for the tick or the serology. You only do maybe serology um you know, when you get the patient at the disseminated state. But you must still start your empiric treatment, even while you're still doing your workup. So don't pick tick testing. Don't pick tick testing. Um, so the next one is babesiosis. So babesiosis, and babesiosis infection. So just like Borrelia burgdorferi causing Lyme disease, babesiosis is also an infection which is caused by the Babesia microbe, and that microbe is transmitted by the Ixodes scapularis tick. So that Ixodes scapularis tick is a big problem. It can transmit babesiosis, it can transmit Lyme disease, it can transmit anaplasmosis. So carry three things: BAB, to babesiosis, anaplasmosis, Borrelia. So because of that, we can have a very high rate of co-infection with Lyme disease too, because both of them, they are transmitted by the same tick, right? And what do we see? This guy is just very similar to malaria. This is just like white man's malaria to me. You know, they have what's it called? Constitutional symptoms: the headache, the fever, the malaria, the weakness, the myalgia. Everything is typically present. But because this babesiosis organism has a very high tendency to cause intravascular hemolysis, so just like malaria, the individual is going to be having serious problems with the blood. There's going to be hemolysis leading to anemia. Our normal pneumocytic, pneumochromic anemia, right? You are also going to notice other changes in the markers, like because of the intravascular hemolysis, like what? Elevation of the LDH level, breakdown of heme can lead to elevated bilirubin, hyperbilirubinemia. Um, Haptoglobin is mopping up all those hemoglobin and the likes. Low haptoglobin, high bilirubin, high LDH, um, anemia because of the accumulation of the bilirubin. You see jaundice, right? So this makes a lot of sense to us. Just think about malaria, kind of malaria-like presentation in the US, right? So when we do our blood smear, what are we going to see? What are we going to see? We are going to see the ring shape trophozoites of this baby cell organism, but most of the time you see them, the merozoites are kind of crossed together, so forming the Maltese cross. So you see the cross sign, the four, pointing one on top, right, left, downwards. So we can look at the picture now. First, we already know the way it looks like, so it's not something strange to us. The mouth is crossed for babesiosis. So this is just more like we are just revising. So we need to also remember the risk factors. So the one that was majorly emphasized in our first stage, step one, was asplenia. So because the spleen is not readily there to help us to clear the red blood cells that are infected with this babesia organism. That's the problem in asplenia. So normally, if the spins are working, the macrophages will come out and they will help us quickly take care of those babesia organism infecting the red blood cells. But they are not there, so they are likely going to be predisposed to developing infection. And it's also very common in people that are immunocompromised, either because they have HIV or because they are using chemotherapeutic agent or any immunosuppressants. Immunocompromised state, malignancy, very important stuff. Old age, more than 50 years. This is a risk factor for babesiosis. And these guys also will be living in some part of the US, just like what's it called? This Lyme disease, they also exist in the north, the north central, the north eastern parts of the US. That's where you sorry, the northwestern, the northeastern part. That's where you see this babesia too. So don't forget about the risk factors, don't forget about the presentation, don't forget about the lab um, features that you are going to see. And how do you treat? So if it's mild, moderate severity, just give AA. AA is always the drug of choice. AA. So you give your azithromycin and your atovaquone, right? Atovaquone, atovaquone or azithromycin. This atovaquone is always oral. It is always oral. So oral atovaquone, oral azithromycin. But if it's very severe, so you use oral atovaquone, IV azithromycin. So that's the way it works for psoriasis. Then moving on to the Rocky Mountain Spotted Fever. So remember we have the other ones too, the epidemic typhus, the endemic typhi, but we are not talking about those ones because it's not very common. Yeah, but we might also need to revise them in our for step one, firstly, just in case. But the ones we are going to lay emphasis on is the Rocky Mountain Spotted Fever, which is caused by the Rickettsia rickettii. R. Rocky, that's where we learned it in step one, right? The epidemic one, P. Rickettsia prowazekii, right? The endemic one, Rickettsia, typhus. So here we are looking at the Rocky Mountain Spotted Fever, the Rickettsia rickettii. So this one is transmitted by the tick called the Dermacentor, which is the American dog tick. American dog tick. American dog tick. So we might we because the states where this is rampant, is not very many. So we can use the acronym AMVCA. We know the AMVCA awards in Nigeria movie industry. The AMVCA can help us. So here for the cancer. So please pardon my pronunciation. The M for the Missouri, the V for the Virginia, the C for the North Carolina. Then the A is talking about the Arkansas again. So Arkansas, Missouri, Virginia, North Carolina. So American ductic, Dermacentor. So what is this about this Rickettsia rickettii causing Rocky Mountain spotted fever? It has a tendency to attach to the endothelial line of the capillaries. So this is just more like our brother the bacillus anthracis, both of them they attach to the endothelial capillary lining and they damage those capillary lining, causing inflammation and eventual destruction leading to restoration of blood, right? So, but individuals with rickettsial usually have constitutional symptoms as well. You can see that this constitutional symptom is kind of common to almost all of them. They would have these constitutional symptoms of routine, and it begins with headache, they have fever, they have malaria, they have a rash. They have a rash. But the rash of the rickettsial rickettii is usually macular initially. So it can be macular rash initially, which begins at the wrist, at the wrist and the ankle. So you just imagine that it starts at the joint, the wrist and the ankle, the wrist and the ankle. Then later, it will now spread out to the distal aspect. So it will move from the wrist to the palm. It will move from the ankle to the sole, you know, and it also move inwards to the trunk. That's what separates it from the other forms of rickettsia, because rickettsia rickettii, which is a Rocky Mountain spotted fever rash distribution, is centripetal. So that means that it's coming from outwards to inward, centripetal distribution. So very important. And when it comes inwards, finally, it now starts transforming into a petechial purpuric rash. Initially it is macular, starting at the wrist, starting at the ankle, moving downwards to the sole, moving downwards to the palm, then eventual inward distribution, which now makes it get transformed to a what? To a petechial or a purpuric rash. One thing I want to mention is that this guy is a very bad guy. You must be prompt in your response. You don't want to wait, because Rickettsia rickettii is a cause of lymphocytic meningitis. So we should not think it's only herpes simplex that can cause viral meningitis and they bring about lymphocytic meningitis. No, we can see that lymphocytic distribution too in an individual with Rickettsia rickettii infection. We can see it in someone that has Lyme disease, right? So don't let us get carried away. It's good to analyze the question very, very well to be sure what you are looking at. So lymphocytic meningitis too can be caused by rickettsia, which can easily progress the patient into an altered mental status, right? Because of the fact that it can affect the vessels, the platelets activation and the likes, can precipitate into DIC, right? So it can cause DIC, it can cause meningitis. So that's why we have to be prompt in our response. So the diagnosis is clinical. Clinical. Somebody living in AMVCA area, Arkansas, Missouri, Virginia, and North Carolina, suddenly developing some confusional symptoms after traveling to those areas: fever, malaise, headache, you know, joint pain, and the likes, and suddenly develops a marco involving the wrist, involving the ankle, spreading to the sole, spreading to the palm, then the trunk, which now changes to the petechial distribution. You know that this is likely to be recurrent. So you having your clinical diagnosis already, but you can also confirm by doing your biopsy. So you take a portion of the skin lesion, those petechial rash and the area, you can take a skin biopsy and you subject it to a PCR analysis, trying to sequence for the DNA of the organism. Or you can do an immunohistochemical testing of that biopsy. And just like what we do for ehrlichiosis, you can do your indirect immunofluorescence examination of the skin lesion. And you are going to notice a fourfold increase in the IgG, in the antibody to the organism. That also helps you to confirm your diagnosis. But trust me, the diagnosis is clinical. So what do you do? Before, as you are trying to be confirming, give your empiric treatment, just like what you do in Lyme disease too. Ehrlichiosis. Give your empiric treatment starting with doxycycline. Don't ever start with tick texting. It's wrong. Empiric treatment with your doxy while you continue with your what? With your investigation. So you have to start your treatment within 5 days because it's very fatal. It can progress to meningitis, can progress to DIC quickly. You know. So if your clinical suspicion is high, you can see that emphasized here. Do not wait for your result. Start your empiric treatment while you are awaiting the test result, right? So in an individual that is pregnant, within the first 2 trimester, you can use chloraphenicol. Chloraphenicol works very well for rickettsia. Chloraphenicol works very well within the first 2 trimester, particularly in people that have the uncomplicated one. But once it's getting complicated or chloraphenicol is not available, give your doxy. Please give your doxy. So if you don't see doxy in the option, don't get confused. Look for chloraphenicol. Look for what? Chloramphenicol for rickettsia. If chloraphenicol is not there, you will definitely see your doxy there, right? Please, and before you pick chloraphenicol, make sure the person is not pregnant. And if the person is pregnant, make sure that it's within the window period, which is the first 2 trimester. Don't forget the great baby syndrome, the bone marrow suppression that can occur from use of chloraphenicol. Um, Yeah, so moving on to infectious mononucleosis, this is something we know. Everybody knows infectious mononucleosis, but I am going to be telling us what we need to focus on to, be sure we are actually picking the right thing for infectious mononucleosis. Number one, we look at the age of the patient. Most of them are usually within the adolescent age group. They are usually young, 14, 15, 16 years. They are not very old, 10 years to like 16. you know, it doesn't occur in old. You don't typically see it in old people. You can't be thinking of infectious because in someone that's 50, 60 years. That's going to be a wrong diagnosis. Most of the time, the patients are young adolescent patient, right? It is caused by Epstein-Barr virus, human herpes virus type 4, very common stuff. How does it get transmitted? Exchange of body fluid, typically saliva. So that's why it's known as kissing disease. Exchange of body fluid, saliva, kissing disease. So how do they present? Everything starts from the head downwards. The head downwards. So they have fever, they have fatigue. They have fatigue, they have fever. You see it like that in the question stem. Um, the fatigue can last for about 3 to 6 months. It can be persistent, right? Then you tell them to open their mouth. What are you looking for in the mouth? you are going to notice swollen, red, exudative tonsils, right? The tonsils are going to be swollen, they are going to be red, they are going to be filled with exudate or pus. Classic for infectious mononucleosis, right? You can check the palate, soft palate, hard palate. You see petechial lesions. All this is still when they have opened their mouth. Ah, say ah. You are looking at the palate, petechial um, rash in the palate. You are looking at the tonsils. Is it red? Is it swollen? Is it filled with exudate? Importantly, you are going to notice lymphadenopathy within the neck. The posterior cervical lymphadenopathy, in fact, it is usually bilateral. That's why you see the statement generalized here. It is usually bilateral. It is usually bilateral. See, bilateral posterior cervical lymphadenopathy, right? Then you come down to the trunk, you can see maculopapular rash in the body, maculopapular rash in the body. About 5% of the cases have this maculopapular rash. Majority of the cases develop this rash because they think the tonsillar exudate is caused by infection with the group A streptococcus, and they begin amoxicillin. So that amoxicillin can cause a generalized maculopapular rash in them. This infection typically involve the B cells. So you notice, we already know this from our step one. It has a receptor for B21, the CD21 receptor. The infectious mononucleosis infection, which is Epstein-Barr, can easily get into the B cells through the CD21 binding, right? So it translocates itself into the B cells. The B cells start proliferating inside the B cells and likes. And the T cells will recognize those B cells as being abnormal and they try to respond to eliminate them. But the T cells that respond to them are atypical T cells. They look regular, they look enlarged more than the normal surrounding T cells. So they are the ones that respond to those B cells infected with the CD21 cells. So the lymphocytosis, that relative lymphocytosis, is going to cause splenomegaly and even hepatomegaly. So that's why hepatosplenomegaly is a common finding in an individual with what? Infectious mononucleosis. So you have to marry everything together. History of fever, history of fatigue. You tell the person to open the mouth because the person is complaining of sore throat. You see, tonsils are red, they are enlarged, they are exudative. Look at the palate, there's petechial rash there. Look at the body, there's maculopapular rash, which is not very common. You palpate the abdomen, there's hepatosplenomegaly, but majorly splenomegaly. You think about infectious mononucleosis. They can have upper eyelid edema. This is not one of the very common stuff, but they can have it. And the symptoms typically present after like 2 to 5 week incubation period. So in older children or adults, they can have mesenteric lymphadenitis. So it can also lead to, because you know that the lymphadenopathy is kind of generalized, but it typically presents bilaterally involving the posterior cervical nodes, but it can affect almost all the nodes in the body. It is generalized. So in young old children and adults, it can cause mesenteric lymphadenitis, mimicking appendicitis. So don't forget the other two infections, which is Yersinia and Campylobacter jejuni. They can also cause mesenteric lymphadenitis and terminal ileitis, mimicking appendicitis, right? Don't forget that. Don't forget that. So, some patients that present with pharyngitis as their primary symptoms, they might be confused with streptococcal pharyngitis. But the thing is, 30% of individuals with infectious mononucleosis are actually carriers of the group A streptococcus in their oropharynx, then symptomatic carrier. So that's why you might need to go on with your investigation, confirm your diagnosis. To be sure, what you are dealing with is not IM, infectious mononucleosis, and don't just assume that it is just gas. So you have to be sure that it is infectious mononucleosis. So what do? Your best initial test is to do your heterophile antibody test. You call that the monospot test. So what you are essentially doing here is that you are obtaining a serum sample of that suspected individual and you mix it with red blood cells from sheep or from horse, a terophile antibody, because individuals with Epstein-Barr infection will have developed this heterophile antibody, which can cross-react to the red blood cells from sheep and from horse. So if it's positive, if there's agglutination, you know that, okay, that person actually has this heterophile antibody, the monospot test is positive, then you can consider Epstein-Barr infection. If it's negative, you can think about something else like CMV infection. Yeah, it can, because CMV infection can present this way. All those things we have said, they will have it. But when you get to your heterophile antibody test, it will be negative. So, in some individuals, they can have this heterophile antibody test negative, but they actually have Epstein-Barr infection. So it could be that maybe it's just very early in the infection and the antibody have not developed. So you can do EBV specific antibody test. So this is not a heterophile antibody. This is antibody that is actually specific to the EBV. So this is much more specific than heterophile. So you order it in an individual that you suspect to have mononucleosis from from Epstein-Barr, and the person is having a negative monospot test. So you have to be sure by doing your EBV specific antibody test, and it should be positive if the person actually has Epstein-Barr infection. But if you are seeing infectious mononucleosis-like syndrome, that presentation and the monospot test is negative, and the EBV antibody is also negative, think about CMV. Think about CMV. Other infection too can include toxo. Toxo can present that way, and even HIV, acute stage of HIV, which we are going to talk about shortly. Um, if you do your complete blood count, what are you going to see? It can shut down the bone marrow too. They can have thrombocytopenia. They will have the relative lymphocytosis, which I've talked about, because you will notice the atypical T lymphocyte, which are regular enlarged T lymphocyte that are proliferating in response to attacking those B cells infected with the EBV. So that's why you have a relative lymphocytosis, because the T lymphocyte arm is what is proliferating. Yeah, you have them more than 10%. So once you see more than 10% of the white blood cells, you know, constituting this atypical lymphocyte, you can think about infectious mononucleosis, thrombocytopenia, relative lymphocytosis. Because it affects the liver, you see elevated transaminases, alkaline phosphatase, and total bilirubin. So, lymphocytosis is caused by B cell proliferation, but the atypical cells are the T lymphocyte. So, just like we have said, it gets into the B cells, they proliferate. The T cells also respond to that, but they are the atypical T cells. So, but the lymphocytosis majorly is due to proliferation of the B cells. It's due to proliferation of the B cells. The atypical T lymphocytes are just responding to them, and you notice that the atypical lymphocyte will be more than 10%. They'll be more than 10%. So once you see more than 10% of atypical lymphocytosis, lymphocytosis basically constituted by the B cells population, you can say that that individual has infectious mononucleosis. So how do you treat? The treatment is support. So please don't forget this statement. Please, very, very important. I think it has come out in some questions. What is proliferating and causing the lymphocytosis is the B cell proliferation. But if you do the smear, you are going to see the T lymphocytes more than 10%, and they are not going to be normal T lymphocytes. They are going to be atypical, irregularly shaped, enlarged T lymphocytes. So treatment is usually supportive. You don't give antiviral treatment. There's no effective antiviral therapy you use to treat it. Sometimes corticosteroid might be indicated, and the way I palm this is just to remember that you typically use your corticosteroid when there's airway compromise or there's bone marrow suppression. That's the way to look at it. Bone marrow problems. So problem with the bone marrow, just think about, okay, problem with bone marrow, maybe hemolytic anemia, maybe thrombocytopenia, and tonsillar enlargement compromising the airway. That's when you give your corticosteroids. So there are a lot of complications that can result from infectious mononucleosis. This includes CNS infection. CNS infection. You can affect the CNS, they can have, think about anything. They can have meningitis, they can have encephalitis, they can have both of them, meningoencephalitis, they can have cranial palsy, particularly cranial 7. Cranial 7 is always the one suffering. Just like in Lyme disease, it's cranial 7. Here too, cranial 7. So they can have optic and peripheral neuritis, optic neuritis, very common in people with multiple sclerosis. You also find it here. Transverse myelitis, in which you notice the person having a particular sensory level, paralysis downwards, and Guillain-Barré syndrome, right? Very, very important. Very, very important. Very, very important. Very, very important. Yeah. Okay. So, splenic rupture can happen. Of course, we know Epstein-Barr infection can cause splenomegaly. So although this is very rare, but it can happen in people that are involved in contact sports. So you try to avoid contact sports for at least 4 weeks for the whole process to subside, because the infection typically clears within 2 to 4 weeks. Yeah, yeah, it's kind of self-limiting. It clears within 2 to 4 weeks. So you just tell them to just avoid contact for 4 weeks to prevent the complication. But if the person is running health scared involving in wrestling, football, they can rupture the spleen. And when there's splenic rupture, we know the way they present. They have abdominal pain. There's irritation of the diaphragm on the left side, left of the diaphragm, which can cause a referred left shoulder pain. You call that the care sign. The care sign. And of course, hypotension, tachycardia, which signifies hemodynamic compromise. So once you are seeing sudden onset abdominal pain, left shoulder pain, hypotension, tachycardia, and the person had 2 weeks history of sore throat, hepatosplenomegaly, blah blah blah, fever, fatigue. You think about splenic rupture from infectious mononucleosis. You know, that is that. Upper airway obstruction. We have said it. The tonsils, they are enlarged, they are red, they are exudative, they can occlude the airway. So that is impending doom. So you quickly want to come to that person's rescue by giving steroids. So steroid is going to limit that inflammatory response, and there's going to be normalization of the airway. So that's when you intervene with steroids. You can have superimposed bacterial infection, just like we have said. About 30% of them can have infection with streptococcal organism. So you can have, superimposed streptococcal pharyngitis. It's important to also know that. Um, Fulminant hepatic necrosis. So this is very common in males, and it's a commonest cause of death in affected males. So we don't specifically know why, but it's just like the lymphocytosis kind of occludes the vessels, and of course can lead to reduced perfusion to the liver because they'll be so engorged with lymphocytes, causing hepatic necrosis. So fulminant hepatic necrosis is very common in males. Um, Autoimmune hemolytic anemia, so that this is another bone marrow issue, right? So they suddenly develop antibody IgG against these red blood cells, and they start hemolyzing the red blood cells, so leading to autoimmune hemolytic anemia. Don't forget, don't forget that. But it is a warm variant, warm variant. That's why I said IgG, right? So which is common in people with some cancers like CLL, like SLE, and the like. So it can also happen with people with infectious mononucleosis, and you have the IgG, which is destroying the red blood cells. And you tend to have, I know we already know the clinical picture, we know the laboratory picture, the smear findings, spherocyte, right? You are going to see the spherocyte there on the autoimmune hemolytic anemia, and if you do your comb test, it's going to be positive because, of course, there's an antibody involved, and that's the IgG variant. So the anemia can last for about 1 or 2 months. So if it's severe, you need to give the corticosteroid to come to the rescue. You give the corticosteroid to come to rescue for thrombocytosis. You give it to come to rescue for autoimmune hemolytic anemia. You give it to come to rescue when there is airway compromise. So the last on the list is the nasopharyngeal carcinoma. So um, Epstein-Barr can cause so many cancer, can cause Burkitt lymphoma, can cause nasopharyngeal carcinoma. But always remember, just like gastric cancer is common in Japanese, nasopharyngeal carcinoma is common in the Asian people, generally. The Southeast Asian, very common. Nasopharyngeal carcinoma. So how do they present? They have a painless cervical lymphadenopathy. You see a painless cervical lymphadenopathy just by the neck. The person will present with epistaxis, so bleeding from the nose. They can have nasal obstruction, difficulty in breathing. They can have headaches. They can have recurrent otitis media. So that's where they like staying. They like to put that the question stem. You can get history of the individual having recurrent otitis media because the nasopharyngeal carcinoma kind of obstruct the osseous tube that connects the pharynx to the middle ear. So the nasopharynx to the middle ear. So that obstruction of drainage can lead to recurrent ear infection, right? So there's recurrent ear infection. So when recurrent ear infection occurs as otitis media, can lead to ear destruction. It can even lead to conductive hearing loss. So the person can have an eventual conductive hearing loss, they can have otitis media, they can have headache, they can have epistaxis, they can have nasal obstruction, and a painless cervical lymphadenopathy. Don't forget, it is a problem of people in Asia. So the carcinoma can present like a neck mass. See, neck mass problem, you know, with the hair, recurrent otitis media, having bleeding from the nose, with a painless cervical lymphadenopathy. Think about nasopharyngeal carcinoma. Um, so just like I've mentioned here, people with mononucleosis who are given ampicillin for subsetted streptococcal pharyngitis may develop a prolonged pruritic maculopapular rash. So majority of what brings about that rash is due to um, iatrogenic, due to our own treatment from the ampicillin.